Good evening, everyone, and welcome to the Behavioral Health Workforce Education and Training Interprofessional Integrated Health Education Series. Today is May 17th, 2022. This program is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, and our grant numbers are listed for your review. I would like to begin by providing a brief overview of tonight's agenda. I am Dr. Katherine Y. Brown, Assistant Professor in the Department of Family and Community Medicine, and also Director of Communities of Practice and Dissemination for the National Center for Medical Education, Development, and Research at Meharry Medical College. After I bring you greetings, you will have a welcome by Mr. Ross Fleming III, Director of Behavioral Health Practice, Meharry Medical College. And finally, our presenter will be Dr. Cynthia Jackson, Behavioral Health Manager, Matthew Walker, Comprehensive Health Center. Following Dr. Jackson's presentation, we will have time for Q&A. Please be sure to mute your microphones during the presentation. We invite you to use the chat box for questions and comments during the presentation. At this time, let's do a virtual introduction. Please type your name, organization, city, and state in the chat box. And again, Q&A will follow the presentation. Let's connect on social media. Please follow us on Twitter at PCTCOP and use our hashtag PCTCOP. We invite you to share your Twitter handle in the chat box, and we will be sure to follow you. Save the date. Remember, tonight's presentation is part of the monthly BHWET Integrated Health Education Series. Our next program will be June 21st, 2022. Also, we are excited to share that the National Center for Medical Education, Development, and Research will convene its 6th Community of Practice Conference entitled The Future of Medical Education and Clinical Services Transformation, Meeting the Needs of Vulnerable Populations. It will be held May 19 through 20, 2022. For information about this conference, please email kbrown@mmc.edu. We've listed our websites, meharrybwet.org, tnahec.org, ncmedr.org, and cwpcmh.org. Please visit to find out more information about our work. Meet the team, Dr. Patricia Matthews-Juarez. You've met me, Director of Communities of Practice and Dissemination, Dr. Katherine Y. Brown. The psychiatry team, Dr. Williamson and Lanique M. Woodson. Meet our team from the Family and Community Medicine Department. They are all listed on the screen. And we have Natasha Yoakley with our TN-AHEC program. And last, but certainly not least, the BHWET administration, Mrs. Veronica Burns and Mr. Ross Fleming III. At this time, I'm excited to introduce Mr. Ross Fleming III, Director of the Behavioral Health Practice, Behavioral Health Workforce Education and Training Program. Welcome, Mr. Fleming.
Good evening, everyone, and welcome to the Behavioral Health Workforce Education Training Lecture Series. It is wonderful to have you here this evening, and I'd like to everybody, May is Mental Health Month, and that leads right into our tonight's topic, suicide and chronic disease management in the patient-centered medical home setting. Through an integrated health approach, the Departments of Psychiatry, Behavioral Health Sciences, and Family and Community Medicine have collaborated to train residents, scholars, providers, and other health professionals to work with persons in rural, vulnerable, and medically underserved communities. This approach will expand the number of behavioral health and family medicine professionals who will stay and work in primary care settings in Tennessee, as well as in rural and medically underserved communities nationwide. Tonight, we have an opportunity to expand our residents and scholars, as well as others' trainings, as we hear from an expert in behavioral health. I hope you will listen and engage in this very important topic this evening. Tonight, our speaker will be Dr. Cynthia Jackson. Dr. Cynthia Jackson completed her doctorate degree in counseling psychology at Tennessee in 2008. Throughout her training, she was introduced to the concept of integrated care in multiple clinical and counseling with behavioral health coordinators and physicians. Dr. Jackson is currently the behavioral health manager at Matthew Walker Comprehensive Health Center for Nashville, Clarksville, and Smyrna locations in Tennessee. For the past 7 years, Dr. Jackson has served as chair for the Nashville Health Disparities Coalition. In her role, she has worked to empower community members in priority populations, groups to seek better health, help change local health practices, and mobilize communities to implement evidence-based public health programs that reduces health disparities across a broad range of conditions. Dr. Jackson believes that if we branch out communities together, we can make a difference for the health and welfare of those we serve. In her spare time, she enjoys spending time with her family and friends, traveling and listening to music. Ladies and gentlemen, I present to you Dr. Cynthia Jackson.
Good afternoon, everyone, and thank you so much for the invitation. I am very excited to be here with you today, or shall I say this evening. If most of you are like me, we've put in a full day of work already. It's so important that in the month of May and every month that we pay attention to the mental health and the mental welfare of the people that we know and that others know and that we know as our community. So again, I am so excited. Tonight, my presentation title is Suicide and Chronic Disease Management in a Patient-Centered Medical Home Setting. And I'll talk a little bit more about what the PCMH setting is, because I'm here at Matthew Walker Comprehensive Health Center, and we are a PCMH facility. I must say before I get started, my disclosure statement is that I don't have any interest, commercial or financial relationships that has coerced me or that I'm receiving for doing this presentation with you all. I just want to make sure that we get the word out so that we are being proactive for all those that we care about in our community and in our families. So a little bit about patient-centered medical home. I was speaking with a colleague earlier today and that knew I was going to do this presentation and kind of gave my title, and my colleague said, well, tell me more about that patient-centered medical home perspective. So I thought, well, great. I'll just include it in the presentation in case someone else had a question about what that particular acronym means. So a patient-centered medical home is a care approach that really brings together an expert team that focuses on you, focuses on the patient, focuses on the person that walks through our door. We begin our medical home approach with our primary care clinic. In that setting, we have an entire team of professionals that work together to provide a new expanded type of care. So what does that mean, new and expanded? And of course, Matthew Walker is not the only facility doing the integrated approach, but we know that it works, and it's important that most facilities treat the whole person. So we have an expert team of providers that will treat you as a patient when you walk through the door. Your provider may be a GYN, it could be a family nurse practitioner, a medical doctor. I want to add, it can be a podiatrist, nutritionist, certainly behavioral health. There are case managers and referral specialists that can get you to the place if you need a specialist, like for instance, psychiatry. We don't have at Matthew Walker, and I know this Part of your team is psychiatry, so I know you all have the bigger picture in mind. And of course, we have a pharmacist. So we're excited that we have a pharmacy. Once our patients are finished with their whole integrated approach to care, get their prescriptions or e-scribe the prescriptions, they can walk right out of the door, jump in the car, go home and start their care to getting better. We want to support the person as well as the family or the caregiver in managing the care. So oftentimes, even with behavioral health, it incorporates bringing the family in is to get better for even the patient themselves. So everyone is included in making a very healthy decision about your care, and we try and do it under one umbrella. So the purpose is coordinating the care, no matter what that is. If it's in our pediatric unit for immunizations, well visits, adult screenings, and specifically more of what we will be talking about in this presentation is chronic conditions, because we know certain populations are more at risk for chronic conditions. And a lot of those type of conditions are people that walk through our door that need help referring to specialists or just dealing with that condition with their primary care physician while they're in the clinic. Some of those special programs are complex, but they need to be addressed. We have to target people's blood pressure. You all have heard about that. A lot of people, even young people, have difficulties with heightened blood pressures. There are a plethora of folks with in our diabetes prevention programs. And oftentimes it's more than just the diabetes itself because of diet or exercise. It could be because of foot care. And then there's some other elevating problems that exist because of those things that piggyback off the diabetes. For breast care and cervical cancer for women, we make sure that we have our OBGYNs in place. And we even service those that are part of the Ryan White Foundation. So those coming in with the diagnosis of HIV are also serviced. We have extended programs for those with hepatitis C, and just a plethora of resources that we can offer those that have chronic conditions at our patient-centered medical home. Next slide, please, Mr. Fleming. So what I intended to show here is that the patient is in the center. That's our big focus. The patient coming through the door, making sure that that patient gets whatever care that we have possible to offer under one umbrella, or that we've made linkages to other facilities and programs and clinics to make sure that the patient is served for the condition that they're coming to the clinic in. So patient in the center, we have laboratory, radiology, and pharmacy, if you're looking to your left. Then there's our nurse care manager. There's the primary care physician that's seeing that person. We have a nutritionist dietitian on site so that you can speak with that person about proper diets to manage your diabetes, proper diets to manage your weight, proper diets to work on those chronic conditions that we're talking about. And oftentimes we have to refer out. We refer to Meharry and to General when we need additional resources for people that are underserved or underinsured or underinsured, uninsured or underinsured. And then sometimes you also need those specialty physicians. And when we know that we have groups of folks that don't quite have the resources or the type of insurance that can get them to some of the more other facilities, then we know that we can make that linkage with groups like Meharry and General that we can send our patients. But the main thing that I want you to know here on this picture is that the patient is in the center. And we are excited that we can have this whole PCMH approach around the patient care. Mr. Ross, next slide, please. So why even do a patient-centered medical home? Well, the research suggests that it's cost saving. if you don't have to go from hospital to hospital and place to place and clinic to clinic and specialty to specialty, and there is one certain umbrella that the patient can integrate their care, there's a cost savings associated with that. If we can get you in and we can have the whole preventive care, and if one of our specialty providers see that you need to be seen by the other specialty provider, for instance, if you come in and you're seeing our podiatrist, but we notice that you're sad or you're grieving or you're anxious, then you can also see the behavioral health specialist. And so based on those things, if we notice that you have a diagnosis of hepatitis C, and there are other underlying conditions that are happening because of that, we're also addressing that. So based on some of that information, we would have fewer ED visits, fewer hospital visits. Of course, again, cost savings to the patient. Improve access makes a difference. We can schedule a patient to see behavioral health, but also return so they can have medication management appointment on the same day. Again, improve access, less time missed from work, increase opportunities to coordinate care with your provider. So the improved access is a win-win situation. And of course, for our patients, we want improved health. This is why we do this. When our patients, specifically certain populations, are pretty much historically known to have chronic illness, we are in the market of getting them better. So improving the health, having that whole integrated care and that PCH model will definitely get us into that space. Patients are excited about this approach. Most times we get client and patient satisfaction that this approach works best for them. And they are so thankful in many situations that we have caught certain things, or we have provided preventive care like mammograms when they leave their PCP, to just go and get a mammogram or to get an x-ray or to get their labs and their blood drawn, to pick up their prescription on the way out the door, or talk to someone like myself. It really helps the patient feel a sense of that people care and that they are here for their health and to make sure that they're doing much, much better. It increases preventive services, as I mentioned all along. So just to have a PCMH model and integrated care has really serviced our community in a way that we're really excited about it, and that our patients are excited as well. Next, please. So what do we want to improve? We want to improve the whole body composition. Mind, body, spirit, from the foot to the head. That's the best way that I can describe it. Your mental health, your feet, everything in between. We're trying to get better. Improving the blood lipid profile, the vascular function, blood pressure. Specifically, it's really been amazing to see that so many young people are having difficulties with regulating their blood pressure. And some of our young people are carrying around a lot of stress. And we don't recognize that unless they have an opportunity to speak with someone, like someone in behavioral health, or get that information to their PCP and have that consultation right there on the spot for behavioral health. Of course, improving blood glucose, any kind of insulin sensitivity, physical function and mobility. It's really important for that. And you can see the rest of the chart. The purpose is when there are chronic illnesses that are presenting themselves, the approach that we're speaking of for the PCMH model in the integrated care is what we would like to do in getting that person in a healthier space. All right, next slide, please. So I talked a little bit about chronic diseases in America, and most of us really know what that is, but I'd like to share this slide with you from the CDC. There are 6 in 10 adults in the US that have a chronic disease. We're over 50%. That's a big deal. And there are 4 in 10 adults in the US that have 2 or more chronic diseases. That's an even bigger deal. And we are seeing those things in terms of those chronic diseases as part of the patient care. A lot of what we see, which are the leading causes of death and disability, and are also the leading drivers of the nation's annual healthcare costs: heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease, diabetes, and chronic kidney disease. I don't know about you guys. I have family members that fall in some category on this page. And I imagine you do as well. And I know we're all muted, but if you can drop in the chat box, if you have a family member or a close friend with any of these diseases, can you just put in yes in the chat box? And we can see how impactful this thing is for our community overall. I see the yeses coming through. They're coming through quickly. Yes, yes. So quite a few. And so we all know how important it is to get the chronic diseases under control or managed. So again, want to share with you all some of the reasons we're having this presentation, because even in our own neighborhoods, even in a small clinic like Matthew Walker, we are seeing quite a bit of the leading causes of death and disability. And it's important to make sure that we know that this is what we're experiencing in our communities and how we can get them to places like Matthew Walker and others so they can get the care that they need. Next slide, Mr. Thank you. So there's an impact on chronic disease that sometimes some of us don't consider. One of the take-home or multiple take-home messages are, it involves more than just physical symptoms. What we're seeing is there are many psychological and emotional symptoms as well, as this particular chronic illness affects people in our community. Oftentimes, the psychological effects of chronic illness can be profound. We hate to think about suicide as one of those profound psychological effects, but the truth of the matter is, it's right up there with the profound psychological effects of someone suffering with chronic illness. And many of you may say, well, why? They're being managed or possibly managed. So what would get them in such a low space? Sometimes people don't have what they need in terms of social determinants of health. They can't get the proper diet, so they can't eat the correct things. They may be overweight and they can't exercise like they used to, or just don't have the energy, or have other illnesses like Hep C that won't give them the energy to do the exercises. Sometimes they don't have the money or the health care, and this becomes perpetual and they give up. And that's unfortunate, but that's the world that we live in. And those are part of the psychological effects of chronic illness. It can be strongly disruptive to your social life, and it actually puts a strain on social support networks. As much as we would like to say that we're all altruistic and we like to help people, and you know, we are that person, people sometimes are so busy living their own lives that the person with the chronic illness starts to feel isolated. And it really does put a strain on their social support networks. And if they don't reach out to someone in the behavioral mental health field, that they can get some tools for their toolbox to help them work through some of the problems, it becomes that of isolation, depression, and may lean towards the unfortunate aspect of suicide ideation. We've seen it. I didn't make it up. It happens. So what happens is individuals with chronic illness are more likely to be depressed, especially those who experience greater levels of pain and disability. I shake my head and I close my eyes. And when I read that statement, it really hit home with me, because this is what the research says. But this is also part of my experience when I'm talking with the patients in our clinic with chronic illness and that are depressed, because their quality of life has diminished to a point where it seems unmanageable. Their social support networks have diminished because the chronic illness has put them in a separate category from those that can still do for themselves. And so if anything else, which sounds really, really sad, this take-home message is so important in understanding where we are with our folks with chronic illness. Please go to the next slide. There are stages of emotional reaction to the chronic illness. Oftentimes, almost like the stages of, oh, I can't think of the name of it, and you guys are with me right now, but there's denial initially. And then there's anger. So kind of in denial, this thing is happening to me. I'm gonna be okay. I don't have to change any of my behaviors. I understand that there's, some things that are going on, and I'm contemplating making some changes. But right now, I don't feel that bad. So I'm gonna continue on my trajectory and nothing's gonna change for me. Then you start to feel a little bad, a little worse than you did. And then you get angry because why me? Why is this happening to me? I'm angry. I can't keep up with my friends and do the things that I used to enjoy. I'm angry because I feel bad and I feel down. I'm angry because I don't have health insurance that'll let me go to the doctor as often as I need to. Or I'm angry because my finances are short and I can't change my diet. I'm angry in general because now I am so affected by this chronic illness that I kind of don't know what to do. And then we oftentimes start to accept the whole partial thing of what's happening with me. So yes, I get it. There are some problems and I need to address them. But right now, there's more important things that I have to do. I don't want to miss work and go to the doctor. If I miss work, go to the doctor, then I may be short on a bill or something. If I miss work or miss my child's game or miss something, so I'm partially accepting this thing. I know something's going on. I know there's something that's different, but what do? Well, I want to keep living life the way that I've been living life. I will check in with the doctor and get their opinion and their advice, and I'll do some of those things. But then life starts to change even more. And it's on a downward spiral. And what happens is that depression sets in. And that's not a good place to be. And oftentimes we can mask that. Like that song by Stevie Wonder, The Tears of a Clown. You're smiling all the time. No one really knows how you feel. And they're not seeing any difference in you because they don't know that you're depressed. But now that this whole thing about your chronic illness is really settled in behind closed doors, when no one's around, you're starting to feel really, really low until at a point where you can't mask it any longer. And you just have to accept what's going on and get the help that you need. but oftentimes we don't know where our resources are in our community. And so I will talk more about how impactful the community can be to make sure that we know everyone or people in our community know where our resources are to make sure that they can get the help that they need. So these are our stages of emotional reaction to chronic illness. Next slide, please. So what happens? Why do you get depressed when the chronic illnesses start to bother you? Well, sometimes there's an impact on our ADLs or our BADLs or our IADLs, which gives us inability to do our activities of daily living. Just those general things, going to the grocery store and, taking the children to their football games, or we can get even worse where we can no longer button up our shirts or smaller tasks that would be more occupational. And then we look at these things under our physical needs, and there are disability related needs, mobility related needs, even those nutritional related needs that I talked about in the previous slide. Their incidents will start to occur, and we may even need wound care. I was talking with my colleague earlier, and part of the podiatry arena that my colleague works in, there was some related wound care to podiatry that has become part of a chronic illness. And there are certain needs that even that population needs that may or may not can get it when it is needed. So all of these certain things will relate to how do I communicate my needs and who do I tell them to? How does this affect my cognitive abilities or my psychological needs? Who do I speak with for psychological and mental health needs? The beauty of the integrated model, the beauty of working in a PCMH type model home will present all of the providers that you need to address these needs that you see on the page. So that's why we're bringing all three subjects together so we can explain the importance of having that whole PCMH chronic illness talk that we're having today. Mr. Ross, next slide, please. So I talked about depression because it can become a problem. On the slide, what you'll see is the US prevalence of chronic diseases and the percentage of depression. So I thought it was interesting that they labeled this sick and sad. That makes me sick and sad just to hear it say sick and sad. But what we're looking at is the US prevalence of depression with people living with various chronic diseases. Those with Alzheimer's, depression is at the bottom percentage of major depression, and then the chronic illness disease is on your left side. So at least 11% of people with Alzheimer's experience depression. Those with cardiovascular disease, at least 17% also experience depression. It goes up. This is interesting. It's not a good copy, but with cerebral vascular disease, 23% experience depression. Those with diabetes, and we know there are a lot of people in our population that have a diagnosis of diabetes, also experience depression at 27%. Ooh, cancer, and we know that whatever that thing is, and I know that we probably have a lot of scientists on the call that can really break that thing down about cancer, but we hear it every single day. Those experiencing chronic illness like cancer are depressed at 42%. And Parkinson's disease, I was really surprised by this number, 51% depression. And the reason I was surprised by it It's not that I don't see the correlation between having the Parkinson's disease and depression, but the fact that the quality of life, because we talked about those ADLs and those IADLs and those BADLs, the quality of life is so decreased and so diminished. I can see why the depression happens. Those are our people coming into the clinic with these chronic diseases and also feeling that depression. And as I talked about depression slightly, a few slides back, often leads to suicide. And unfortunately, that's what we're experiencing in our communities. And unfortunately, since the pandemic, and I'm sure you guys have heard this many times, although the sadness was there, the sick and sad, after the pandemic, when people were isolated, when people were not coming out of their homes, when they became more anxious about being out in public, when they didn't get quite the care that they probably needed, depression has gone up tenfold. We have an enormous amount of mental health cases coming into the clinic every single day. I do remember today is Tuesday, so this probably happened Friday. First thing in the morning, within 2 hours of being in the clinic, I probably saw 4 people, and 3 out of 4 completed a screening and checked that they had suicidal ideations or that they felt like life was not living and that they would be better off dead. It's sad, guys, and I am not making this up. Just to think, many of those people did not have chronic diseases. So this is tenfold for those with chronic illnesses. And it's really, really important that as a community that we make a difference. And so I just wanted to throw that out there. Hope I'm not making you sad. This is the reality in which we live. Next slide, please. Again, prevalence of major depression on some other chronic illness. I think we kind of had all of these, so we can skip this slide. So having a mood disorder, the only thing that's different on this one, I believe, is showing no chronic condition and still having 2.8% of a mood disorder. No chronic condition, but there's still some type of mood disorder. That's why we are so excited to have the behavioral health piece as part of our integrated setting, so we can catch each and every category of every person that's coming in with something that may not be 100% I'm okay. And even sometimes when you hear I'm okay, people are not okay. And it just takes time for someone to listen to them or to help them understand. The more you repress those feelings, the more layers in your volcano that you build. And what happens after the layers of your volcano? There's an eruption. And it's going to come out some way. Headaches, stomach aches, depression, suicide, anxiety, all that are negative. So we are asking people right in the physician's office during our consultations, in certain ways that we present our information, how can we help? Let's get you in here. Let's talk about those things. Let's give you some coping strategies. Let's see what's not working for you. And sometimes it's because people are experiencing, again, those social determinants of health. You would be surprised, and maybe not, how many people are homeless since the pandemic. You may or may not be surprised how many people don't have food to feed their children, and I mean their babies. Things are happening in our society, and people become hopeless because of the chronic illness, and sometimes not because of the chronic illness. But this slide was just to show you that there are other no chronic conditions that's bringing on those mood disorders. Thank you, Ross. Next slide, please. So how do we broach the conversation when patients come into our office? You may not can see it, but I can kind of walk you through it. So all new patients receive screeners, depression, anxiety, opioid risk tools, alcohol screenings, drug screenings, marijuana, and so forth. And we check the patient scoring after they complete the screening. Some of you may have seen the screening, and if not, let me explain it to you in the way that we have intended to use it. The PHQ-9 depression screening is a 9-question patient health questionnaire. It's a diagnostic tool. It was introduced in 2001. So really not that long ago, or didn't seem like that long ago, but we're in 2022. We use this to screen adult patients in primary care. So it's perfect for the setting in which we're sitting in. It looks for presence and severity of depression. So it makes a difference on the severity of depression. It's a self-administered patient report questionnaire, which we get a full picture because the patient is telling more about themselves than us speculating or observing. Takes less than 3 minutes to complete. And then we just simply score it. And we score it based on the DSM-5 criteria now for depression on the mood module. Most primary care physicians use this frequently to screen for depression in patients. So what you may not see, and I can go over this with you, of the 9 questions. Number 1, ask, and let me back up. We ask the patients over the past 2 weeks, have you felt any of the following? The responses can be not at all, sometimes, most of the time during the last 2 weeks, or nearly every day during the last 2 weeks. So number 1 is little interest or pleasure in doing things. Number 2, feeling down, depressed, or hopeless. Or feeling as if trouble falling asleep or sleeping too much, feeling tired or having little energy, poor appetite or overeating, or feeling bad about yourself, thinking you had let your family down or let yourself down, trouble concentrating, like watching TV or reading the newspaper. Also moving around so slowly that other people have noticed and wonder maybe what's going on with you. And number 9, which sends chills up my spine every time I see this, and the number that circle is not 0, meaning it is a 1, 2, or 3. And the question asks, do you have thoughts that you would be better off dead or hurting yourself in some way? I share with you all more often than not, at least 30% of the population in any given week will circle something other than 0. Oftentimes it's more severe than others. Sometimes it's just a latent thought, like maybe if I just went to sleep and didn't wake up, nobody would miss me. All of my worries, my pain, all of those things would be over and I won't have to feel this way anymore. Or to 3, I feel this way. I thought if I just go out and walk in front of traffic, then I can just end things. I don't know about you all, and I imagine you probably feel the same way that I do, but that just really saddens you. Speaking of sick and sad, when people feel that life is not worth living. The beauty of having the primary care setting, the primary care medical home model with the integrated setting is that this person did not come in just because their diabetes was bothering them, or it was just a checkup for diabetes, and didn't get their mental health addressed as well. So we have crisis interventions in place. We offer them therapy if need to. If we need to refer them to mobile crisis and have an evaluation, or have mobile crisis come in and evaluate them, and they don't do that as much since the pandemic, or if we need to just schedule them for a therapy session or have them hospitalized. The major thing is we've caught it because they walk through our PCMH setting, because we've offered the integrated care, and because we caught it before they walked out the door. That's the beauty. That's what we're looking for, to service our community in the way that the community should be serviced. Next slide, please. It's tough. It's tough when someone talks about suicide. If you look at the pictures, one of the toughest parts of life is deciding to give up or to try harder. It's tough when you hear a young person, 15, 16, that want to just walk off a cliff. Or it's tough when you hear an elderly person that's grieving and lonely and has additional 2 or more chronic illness ready to give up. Our greatest weakness lies in giving up. The most certain way to succeed is to always try just one more time. We hope to be an inspiration to those that come into the clinic with chronic illness or on the brink of giving up, to try at least one more time of just feeling better enough so that they don't give up. Next slide, please. So here's the scoring for that PHQ-9 that I talked about. The total sum of the responses suggests that there are various levels of depression. The scores range from 0 to 27. In general, a total score of 10 is suggestive of presence of depression, but I'm telling you guys, we don't go by that. If that score is above 5, 6, and better, then we need to address this thing. Because I feel that if it's a score of 10, you're already experiencing moderate depression, and it's just a point away from being moderately severe and not that far away from being severe. So each level of depression suggests the type of intervention. I imagine there are other behavioral health specialists on the call that may agree with me. Why wait until the score is 10? Of course, 0 to 4, none is minimal, nothing that we should do. I still talk about it. Like, kind of, is this situational? Kind of what's going on. 5 to 9 is kind of a mild depression. When we see the patient again, we repeat the score. I have instructed my team to call the patients and a follow-up time, even if they're not coming back into the patient-centered medical home, we have a follow-up list. Give them a call, fill out a new PHQ-9, get them back in here for therapy, whatever we need to do. We're not just gonna wait. 10 to 14 is kind of moderate. You make a treatment plan, consider counseling. I disagree. Offer them counseling, if not with you, with someone else. Follow up, and perhaps the PCP will prescribe some type of antidepressant medication, or we can send them out to psychiatry. We can make that referral. That's part of that whole patient-centered medical home approach. That's why we have it in place. When there needs to be a referral made, then we do that. 15 to 19 is moderately severe, prescribing prescription drugs and counseling. So they're like, hey, do everything. And I say, do everything before then. This was 2001. I don't know if they know about after the pandemic, and kind of anything before that, again, I disagree waiting for the score to be 10. And then 20 to 27 is severe, prescribed prescription drugs. If there's a poor response to treatment, immediately refer the patient to a mental health specialist for counseling. And I kind of agree with numbers 15 through 27. However, that was part of the research, but I also say this is 2022. So use appropriate judgment. All right, next slide, please. So there are about 32 people.
Dr. Jackson, I just want to give you a quick just time check. It's about 6:20. You're still good, but I was just letting you know we're being enriched. And for those of you all who are on tonight's webinar, please begin to put your questions in the chat as well for Dr. Jackson. Thank you, Dr. Jackson.
Thank you, Dr. Brown. All right, so we're getting closer. So what do? There are about 32 people in the car. And if you all remember what I said, we are the community. And we have to address the issue of chronic illness and suicide to folks in our community. We need to connect stakeholders. We need to create spaces for dialogue. And there is a way to do that. I did a little bit of research and I found from the World Health Organization an entire toolkit to get us talking in the community, involving multiple stakeholders to get us there so that we can address this thing, so we can take it to the people. Because everybody's not gonna walk into Matthew Walker, everybody's not gonna walk into Meharry, or whatever organization you're working in. That's why when my bio was read, and the second part of my bio, the part before what I like to do in my spare time is travel and spend time with family and listen to music. What we need to do is, I see you, Dr. Burns, is to make sure that we get the, how does a non-healing wound on the lower extremity? Okay, we'll get to that. So what do? We get some stakeholders together. So next slide, please, Mr. Fleming. So here is the website, and you all will have it. Preventing Suicide, a community engagement tool. And what I started to say was that part of my bio that talked about the Nashville Health Disparities Coalition, which I am the current chair, and I've been that chair for the last 7 years, is that we're out in the community trying to engage people. Part of our mission is to reach health equity and to connect people through education and advocacy. Part of our vision is to make sure that we have an inclusive network of partners so that we can eliminate socioeconomic disparities and be out in the community doing the work that we need to do. So there is the link. I just want to take you to a couple of the first pages, just to let you guys know that this tool exists, that we will be doing this work in the Nashville Health Disparities Coalition. As a matter of fact, we meet every third Friday of the month, and we meet by Zoom, which is perfect. Thank you, pandemic, because it works for everyone to make sure that we get there. So Mr. Fleming, are you going to switch us to that link? Ah, there we are. So I found this really dynamic toolkit. And Mr. Fleming, if you don't mind, will you flip to page 9? That's where we are. All right. So part of what we're trying to do, and that the Nashville Health Disparities Coalition, along with some other stakeholders in the community, we've been talking about this thing. We had a meeting with Meharry Vanderbilt Alliance last week, and a month prior to that, we identified what's pressing in the community right now. And where do we go from there? So we're in the planning phase of the different types of ideals and things that are happening in the community. At least 30 people said mental health and social determinants of health are the biggest things that we need to, as a community, to address. So as we move forward into our goals, we're going through, like this says, our initial preparation. Part of the broad goals would be to prevent deaths by suicide or suicide attempts, to create that community supportive environment. And we're going to develop some short-term and some long-term plans to provide ongoing suicide prevention in our communities. And as you can see, if you'll just go up this page a little bit, in terms of putting together a steering committee, there are a list of different types of community stakeholders that we want to bring to the table. We have some, but there is never enough, because there's enough work in the community for everyone to do. So just wanted to bring that to your attention. If you'll go to page 10, please. At the bottom of the page, we want to make sure that we develop and facilitate appropriate suicide prevention for our community. So what we want to do is a bottom-up approach. We want to make sure that we're listening to the community. We're hearing what they say that they need from us, instead of, like many of us as researchers, take our ideals to the community. So it's important that we're actually listening. Next page, please, to 11. Doing a little bit of our homework. We've not gotten to this point yet, but we're going to look at suicide in our communities, figure out which communities that we need to address first and foremost. Look at those hot spots. Look at what type of infrastructure we have to roll out the different programs. Look at all of the socio-cultural context, the health and welfare of those people in those communities, and what other factors that might be in mind that we need to check out. If you'll go to the next page, some of the stakeholders that we'll need are politicians, parliamentarians, healthcare providers, community and faith organizations, and other people like yourselves that are on this particular Zoom format. So I won't go through this whole thing. It's just dynamic. It will help you walk through some of the things that we will be doing upcoming for the community, so we can fight this whole thing about chronic illness and suicide and non-chronic illness and suicide, so that we don't have to see the people walk through the door feeling depleted, feeling as if there is nothing else to live for, that life would be better off if they were not here. So I just want to make sure I leave that link with you. Mr. Fleming, can you switch back to the PowerPoint, please? And I imagine there are some questions in the chat box, and that's where we're going now, to the slide that talks about questions or comments.
Well, while we're pulling that slide up, we just want to say thank you so much, Dr. Jackson. Can we give Dr. Jackson a virtual round of applause in the chat? Oh, you even got some physical applause going. We appreciate you for sharing your knowledge and your expertise. And we do want to encourage all of our attendees, please, you can unmute and ask a question, or you can use the chat box. I know Dr. Jackson wants to hear from you. We have, let's see, lots of hand claps coming in, as you see, from Kate. Frank, thank you for this important review of current upward trend in depression and need for more screening and treatment in the PCMH. And then you saw the one from Dr. Burns. How does a non-healing wound on the lower extremity affect depression? And then great presentation, very informative. Thank you. So
Thank you all. So I think I can start with Dr. Burns' question.
Yes, please.
Yes, so thank you. And so Dr. Burns, if it's okay with you, if you will unmute, if you will share with the participants and with myself, kind of what you're hearing from your patient that you probably have in mind about the wound and how they've been feeling.
Well, I'm unaware. Can you hear me?
I can.
I'm unaware of the percentage of patients and what level their depression is. I just know that with a non-healing wound on the lower extremity, there is some depression, especially if that goes for a long period of time.
Mm-hmm. And I agree with you. I've actually seen some of your patients come in with problems with limps or problems with lower extremities that also affect their back, that also affect their quality of life, those ADLs that we've talked about. And so what we will do, and I know that everybody's kind of been shorthanded and very, very busy, is for your patients to make sure we get that screening in your into the patient room with the patient so that we can address their mental health needs.
Thank you so much.
You're welcome.
Thank you, Dr. Jackson. And I also wanted to be sure, I'm going to go to the next question, but I do want to say a good evening to Dr. Irene Sandvold, who is our HRSA project officer. Irene, did you want to unmute and say hello to everyone this evening? It's always an honor to have you join us. All right, well, if you decide to unmute, we're here. All right, so we're going to go to a question from Dr. Matthew Suarez. Oh, there she is. Hey, Irene.
Hello. Thank you very much for this very informative presentation and so important. I really appreciated being here. Thank you.
Thank you. So Dr. Matthews Suarez's question is, the rise in suicide among Black adolescents is severe. What are we doing in the FQHCs to address this acute problem?
Okay, thank you, Dr. Juarez, for that question. It's ironic because that's something everyone is talking about. As a matter of fact, when I mentioned to one of my other colleagues today about the talk today, and we focus more so on the PCMH model and chronic illness, because that kind of was the topic. My colleague said, what about the youth? Because it's really a big deal now. How do we get to the churches and get in front of the congregation or speak to the health ministries and start talking more about that? And I think that's great. And people may say, well, they're in a house of faith and they get to pray about it. And prayer is great. And those who are believers and whatever your belief system is, it is very, very helpful. What we need is more professional counseling for the youth or more programming in the community. If we have to get to them through song, whatever that mechanism is to get their attention, then we work on that. One thing that we are doing at Matthew Walker, we have a satellite clinic at Pearl-Combs High School. So for the month of May, we've been more present. Things that make them excited, we have the wristbands that all of the children are wearing. The silicone, the rubber type that talks about mental health awareness. The teachers are wearing lanyards that talk about mental health awareness, bringing more awareness to the fact that there's possibly a stigma, but you don't have to feel stigmatized by what other people are saying. So it's just being more present in the community to make sure that we're letting our youth know where you can find us, where your resources are.
Thank you. And it just says, thank you for your very informative presentation. Excellent. Does anyone else have any questions for Dr. Jackson at this time?
Yes, this is Mr. Fleming. I do have a question. and it concerns the military. Now, there's been a lot of talk going around with military when they're suffering in silence, and that silence, when they're suffering, it's the cause of PTSD. So when they talk about PTSD, I just really want to know if that's considered as a chronic disease, and how do we, what are the measures to take to service the military and to help them with, the suffering and the pain that they're going through, and mostly they're just not telling anyone anything.
Well, I've not heard that PTSD is a chronic illness, but that's food for thought. And so I'm going to look that up when the presentation is over, probably tomorrow. But in terms of the military, and there may be some other military folks on the call, and I would love for you to chime in, but they have a system in place where they have a lot of their own providers, and they can go outside, because I've had a couple of military personnel come to me for therapy, but they started with their own first. And even when that happened, it was more kind of a work relationship dynamics versus I have all of this bottled up from combat and from, being in this very strenuous platform. And so I really think more or less that they're working through their own system. And if we can get to them, that would be great. We recently had an event with Fort Campbell. At the time, it was Sexual Assault Month, so that was the topic. But if we could get to them, we certainly would. I've worked with Operation Stand Down before they remodeled. I think it was over here off of 12th Street or 8th Street or something like that. And when the fellas came in for therapy with me, it was many, many years after combat, many, many years after homelessness, after drug indulgence, many, many years after so much that had piled up. It was like tipping the iceberg just a little bit, because they needed the help way before then. And so if we could get into that population, it would be wonderful. It's just almost a little difficult. And so, and I see Natasha's question. So if anyone else is on the call that's military that can give us kind of a insight to that, I would love to hear it.
And before we transition, I know you're going to answer Natasha's question. I do want to make a reference. Mr. Fleming has put the survey in the chat box. We want you to continue to stay and ask more questions, but we also want to make sure that before you log off, you please take a moment to complete the survey. So we're going to go back to Dr. Jackson with questions, and then we'll transition to Mr. Fleming for closing remarks.
So I don't see the question up any longer. Natasha, would you like to ask me, or would someone read it for me? I just saw it pop across.
Why is the PHQ-9 depression tool so dated? I'm sure that other health professionals feel the same as you with the scoring rating for patient care or treatment.
Right. So Natasha, I don't have a direct answer for that. I do know that sometimes with the research, when it works, it works. I also feel that there needs to be a lot of science behind when we have screening tools or any other thing that's going to measure. I don't care if it's forensic, anything that's going to measure something that's so impactful in people's lives, that we utilize it to the best of our ability until someone else does the science. And of course, any of those screening tools have to go through a rigorous process, and then use our own personal judgment on how we utilize the tool and the interventions that we come up with, depending on the population that we're dealing with at the time in which things are happening in this world.
Thank you. At this time, we also want to announce, and I know you all may have some questions that you're thinking about, so I'm going to give you a moment to come up with any final question. I do think we may have time for one more, but at this time, I would also like to make an announcement. Our upcoming Communities of Practice Conference is this Thursday, May 19th through Friday, May 20th, 2022. The conference title is Sustaining Curriculum Transformation in Primary Care Education and Medical Schools. We have a hybrid format this year that we're very excited about. You can attend virtually or in person. Please email kbrown@mmc.edu. Again, you can email me directly, kbrown@mmc.edu, or you can send me a direct message in the chat box at this time, and I will get you an invitation. Thank you. I'm just looking, Dr. Jackson. Well, I will just ask you, what would you like to share with the group that you did not have an opportunity to share? And we'll let that be your closing thought for this evening.
Okay. I'd just like to share that I am so thankful and I feel so excited that you all gave me your attention and this late evening, that you let me share my passion about the work that we have to do in mental health, and that you join me in our community engagement that we're so looking forward to doing, because we all know that this is a big deal. Mental health is one of the bigger obstacles that we have to face today. If you would like to join us at any of our Nashville Health Disparity Coalition meetings, I have on the last slide, we don't have to go back there. I can give you the person's information. If you'll put it in the chat for me, Mr. Fleming, to receive an invitation to those meetings. It's A. Robinson at mwchc.org. That's Amber Robinson, just A. Robinson, and she'll be able to send you an invitation so that you can join those meetings, so we can get those stakeholders, community stakeholders together. Then we can get out in the community and work with the youth and work with other folks. And Dr. Brown, I know, has a good connection to our youth population, and really look at this thing for mental health.
Thank you so much. Again, we truly appreciate you. And you know we're going to call on you again. So continue to answer when we call. At this time, I will turn it over to you, Mr. Fleming, for closing comments. Thank you all again.
Thank you, Dr. Brown. Thank you, Dr. Jackson, for accepting our invitation for that very informative presentation this evening. I do have some questions that I would like to ask you offline pertaining to suicide and how we can further prevent suicide in young people as well as young adults. So if there are any questions that we have from our residents, our PGY1 residents for psychiatry and family medicine, please at this time ask your question. If not, I'd like to thank everyone for being on the call this evening, especially our residents and our scholars. Our last presentation will be on June 21st of this year. So please look forward. I'll look forward to sending out the invitation, and you look for it coming out soon. And so if there are not any other, thank you for joining us this evening.
Thank you, guys. Have a good evening.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye. Excellent as always, Dr. Jackson.
Thank you, Dr. Brown. I didn't know you were going to be on this platform with us. I'm always glad to work with you.
Thank you.
All right. Thank you, guys. Have a good evening.
You
Thank
too.
you, Dr. Jackson.
Bye.